Assalamu alaikum مرة تانية. It is my great pleasure to be with you this time online. I've been once to Algeria, so this is my second time, but virtual. Hopefully, third time will be physical again. So without further ado, because I'm in my clinic right now, this is my disclosure. The left atrial appendage closure, as you already covered in your conference today, the whole idea is about 90% of AF-related strokes are coming from the appendage. That's why we thought to close the left atrial appendage to prevent stroke, and the patient can stop anticoagulation as you have covered. I will go for the technical issues, but quickly, this demo will show the steps, and then we will relate from the imaging point of view. So of course, transseptal puncture, like anything done in the left side, we have to puncture the septum to cross to the left side, and then the guide catheter, and then the wire will be positioned in the left upper pulmonary vein, and then the pigtail, which is the safe one to be put inside the left atrial appendage, and then the sheath will go over the pigtail, and then contrast will be injected to opacify the appendage in order to be measured. And then the device, which is here in my lecture, I will be covering the Watchman device, will be unsheathed, and then the device will be deployed. Here they are doing tuck test in and out to make sure it is really caught within the appendage. And then if everything is okay, they will just deploy the device. After 45 days, we repeat the transesophageal echo again to make sure that there is no gaps in the cellularization happen, and then the patient can safely stop anticoagulation. So based on that, what is my role as a transesophageal echo person in this kind of procedure? Of course, I have to assess the appendage, but in terms of what? I have to exclude any thrombi because we are going inside the appendage. So any thrombi inside will be very risky. Number two, I have to assess the shape of the appendage. Number three, how many loops this appendage has, and then the dimensions of the ostium and the length of the appendage. Of course, thrombi is quite common. We're dealing with patients of atrial fibrillation, so that's why we are doing this. But a thrombus in the day of the procedure is a contraindication because we're going really inside the appendage. Unlike other kinds of procedures like mitral clip or other things, maybe we can forgive a small thrombus inside the apex of the appendage, but of course not a large one like this. But left atrial appendage closure, no thrombus should be allowed within the appendage. Number two, the shape of the appendage. Appendage is not one shape. Of course, the common shape that we all think about is the windsock type. This windsock type shape, which is narrow neck and long limbs. This one is the favorite shape for the left atrial appendage closure because it has a small ostium and long limbs. If the ostium is small, the device itself will be small, and if the device is small, the legs of the device will be short. So if I put a small device here and the legs are short, they will not reach the top of the appendage or the apex of the appendage. So the device will be very well seated at the ostium. But look at the other extreme, which is the Brockley type. Very wide neck, very wide, and short length. Of course, a very wide neck, very wide ostium means I need to have a very wide device, a very big device. If the device is big, it is not big only in the head of the device. The legs also, the spider-like legs will be down very long because it is big. If the device is big and the legs are too long, if the appendage is shallow, like in this case, the ends of the legs will touch the floor of the appendage, and then the device will bulge outside the appendage. This will create something called the shoulder. The shoulder is thrombogenic, so we do not need a shoulder in the left atrial appendage closure. The appendage has to be at the level of the ostium. What if the appendage has this chicken wing type shape? So a first arm going down and then a second arm going somewhere else, like chicken wing. We don't care about the other wing if the length of the first arm and the ostium looks like the windsock one. So we will deal with this one only. If it is very wide and short, we will deal with it as Brockley type. If it is small and long, we will deal with it as windsock type. So it depends on the first arm or first leg. What about if the appendage has multiple lobes? The shape and all of these analysis is based on the major lobe of the appendage. So we're not quantifying every one. The major lobe, the one at which we will position the device, is the one that we should assess the shape and dimensions and so on. The number of lobes, this is what I was talking about. Before, like maybe like 15 years ago, I was under impression that most commonly we have one lobe, and that was not true actually, because most commonly we have more than one lobe. About 50% of those sitting in the auditorium in front of me now, 50% of you has two lobes, okay? And only 20% of us, or of those sitting in front of the screen now, has only one lobe. So 20% of us. That means when you screen a patient for a thrombus or for the appendage closure by TEE, you should think that this patient is most probably is having more than one loop, okay? And in order to exclude thrombi, we need to screen all the loops to make sure that you covered everything, because most probably this patient or this individual will have more than one loop. What about the size of the appendage? Of course, you have covered this, but we have tables. If the ostium is between this number and this number, and then the device size, the suitable device size will be like this. And if the ostium is like this, the device will be like that. And of course, you can notice that we are usually oversizing the device a little bit because it has to be squeezed and compressed inside the ostium of the appendage. So imaging, where to size and what views should we take? If you are using 2D transesophageal echo, two dimension only without 3D, because the appendage is not a circle, it is many times it's a bit oval. That means one dimension will not be enough. If it is a circle, one dimension in the middle will be enough. But because it is many times oval a little bit or bizarre shaped like that, so you need to get that in many degrees. Of course, 0 degrees like this. If you pull the probe up, you will have a view like this. And then you freeze and measure in front of the ostium of the circ. And then from the limbus here of the common ridge, you go down about 1.5 centimeters to 2 centimeters, and then you measure the ostium of the appendage. And from the mid of this line, you take another distance till the apex of the appendage. This is called the usable length, the length of the appendage and the ostium of the appendage. This is one. And then you do the same thing at 45 degrees. Again, you measure the ostium and length. The same thing at 90 degrees, and then you measure the ostium and length. And the same thing at 135 degrees. 135 is usually the longest length of the appendage, and it simulates the one in fluoroscopy, and you measure the ostium and length. Why is that again? Because it is not a circle in many situations. If you have 3D TE, it is much more easier than this, because one volume like this volume is only for the appendage and the left upper pulmonary vein. This is an en-face view for the appendage. This is the whole appendage, and you can see it's oval. It is not a circle. So mitral valve, aortic valve, so aortic valve, mitral valve, like long axis view. And then this is the anterolateral commissure, A1, P1, and then this is the appendage, and this is the ridge, common ridge, and this is the left upper pulmonary vein. From this view only, one acquisition is quite enough for me to get all the measurements I want, because I will put it in the MPR, multiplanetary reconstruction, in the 3D analysis station or the machine, and then I can put my lines exactly at the ostium, put the other lines in the middle of the appendage, and then I can get an ostial view of the appendage. Of course, 2D transesophageal echo will not give you an ostial view. There is no access in 2D TEE that gives you an ostium of the appendage. But by 3D TE, we can analyze that like CT, and you can see it is quite dynamic. Okay, you can see that's very dynamic. So it is not only at any time of the cardiac cycle, usually in systole is the widest dimension of the appendage. And the same thing, we measure the usable length of the appendage in all the views like that. And this is very well correlated with the CT measurements, provided that you do this in systole, at end systole, not at any other phase of the cardiac cycle. During the procedure itself, of course, we have to cross the septum, as we said, we have to do transeptal puncture. If you're using 2D, the two main views for transeptal puncture, you start usually by the bicaval view, superior vena cava, inferior vena cava. That gives you the superior part of the septum, inferior part of the septum. And then the short axis base view, that gives you the anterior part of the septum and the posterior part of the septum. In the left atrial appendage closure, we usually prefer to be in the inferior part of the septum. And then usually the interventionist pulls the catheter from the SBC going down, down, down till he reaches the suitable spot at the septum from the bicable view. At this moment, I tell the interventionist to wait for me, and then I will go for the short axis base view to make sure he is not in the anterior part. I have to be in the posterior part of the septum because the anterior part has the risk of puncturing the aortic root from inside. The needle has a bit of curve like that. It's not straight needle. Transeptal puncture needle, as you saw in the conference, once it crosses, it has a chance of going like this and hit the aortic root from inside. But if you are in the posterior part of the septum, you are safe. This anatomical illustration is showing you the interatrial septum from the right atrial aspect. This is superior vena cava, inferior vena cava, tricuspid, aorta, and this is the pulmonary and so on. So the septum is flat in front of you, like the right anterior oblique view in the fluoroscopy. The 2D TEE gives you the bicaval view, which is almost at 90 degrees, bicaval view, and then the short axis base view. But they are still 2D planes. If you are using three-dimensional echo, you can do much more easier and better way of seeing the whole septum. Something called Rattle 90 maneuver, which is a maneuver that we have published about 8 years ago, or maybe 10 years ago. Rattle stands for rotate anti-clockwise, tilt left for 90 degrees. Rotate what? Rotate the 3D volume. So I'm now speaking to my echo colleagues. This is only for echo guys. By caval view, you click the 3D zoom. 3D zoom will give you two boxes. You put the boxes at the septum, cover the whole septum, superior vena cava, inferior vena cava. You make sure that you take the septum, but take the septum only. Do not take the right atrial wall. You need only the septum in both views. Take part of the aortic valve and posterior part of the septum. Now you are ready. And then you click 3D zoom again, you will get this view. This 3D zoomed view is having the same orientation of the 2D view. Superior vena cava is here. This is superior vena cava, inferior vena cava, inferior vena cava. Left atrium is here, right atrium is here. Okay. Now rattle will start. Rattle at the end, what I want from the rattle 90 maneuver, by cable view, the septum is flat. But I need to see the septum flat in front of me like that in anatomical oriented view. So superior vena cava, inferior vena cava. I need to see it like that. So what to do? By cable view, you acquire by the 3D zoom. You do rotate anti-clockwise, tilt left. RATLE. This is rattle 90 maneuver. You rotate anti-clockwise, you will get the superior vena cava superior. Right atrium is down. Now right atrium is here. And then tilt left, you will face the septum. And this is how we do it in real life. Superior vena cava, inferior vena cava, left atrium, right atrium. And then now we'll click 3D zoom, get the boxes over the septum. You will have this volume. And then rotate anti-clockwise. And then by the trackball, tilt left. You will see the septum on fast view. This brown color is the gain. Reduce the gain down, and then you will have a very nice view for the whole septum. That patient had an ASD, by the way. Superior vena cava by some forward tilting, and then some backward tilting, you will see the SBC, Eustachian valve, coronary sinus. So this is what the 2D will give you, and this is what the 3D will give you. Very panoramic view for the whole septum, and then you can use it for transeptal puncture, like this. Now the catheter is coming from the inferior vena cava towards the superior vena cava. This is the coronary sinus. This is the aortic valve, ascending aorta, and so on. So you know anterior, posterior, superior, inferior. And this faint part is the fossa. So you can guide the interventionist where to go, and even you don't need to speak. The interventionist can see the fossa here, and this is the catheter. And then now he is pulling down the catheter towards the fossa like that, the needle, I mean. That's another example. The needle was too anterior. Then he rotate clockwise, and then he fell inside the fossa, as you can see. And you can see this from the side by tilting more, or from the left atrium, you can see the tilting more and more, and so on. Good. So now we crossed, and this is the catheter inside the left atrium, facing the Coumadin ridge, left upper pulmonary vein here, and this is the left atrial appendage. Of course, as any step in the left atrium, we need to throw a wire in the left upper pulmonary vein, and that can be guided by 2D or 3D TE live, 3D zoom mode for the mitral valve, ridge, left atrial appendage is here, left upper pulmonary vein. So you can make it easier for the interventionist to show him what is the appendage and where is the left upper pulmonary vein. Now, after wiring the pulmonary vein, this is the pigtail catheter. You can see the pigtail catheter with the uh, curved tip. Now, that's a panoramic view from above both atria. This is the right atrium, interatrial septum. Catheter is coming from the right side, puncturing the septum and going inside the appendage. So now I'm inside the appendage intentionally by the pigtail catheter. This is the pigtail catheter here, and this is the sheath. Now injecting contrast, as we said before, in order to opacify the appendage, and then introducing the sheath like that. And this is how it looks in fluoroscopy. They can see the tissues, they see only the metals. And then now unsheathing the device. The device will pop up immediately like this after unsheathing. Once the interventionists do this, everybody actually will stop and look at the echo guy and ask the echo guy, okay, tell us, should we release this device or there is any problem? So what are the criteria done by echo to tell the interventionist you are okay or you are not okay? Something called PASS criteria. PASS stands for position, anchor, size, seal. Position is what? As we said before, the position, we need the device to be at the ostium of the appendage, not high, so it will create a shoulder, and not very low inside the appendage. That means you left a small part of the appendage also. You left a small appendage, which is thrombogenic also. You need to be at the ostium of the appendage. Number two, the anchor means you need to make sure that the device is compressed inside the, is not compressed, it is caught, well caught inside the appendage, it is not loose. And then you do the tug test, as we'll see later. And then the size means the device size uncompressed has, for example, 21 or 23. We need to make sure that it is smaller than this inside the appendage. That means it is compressed. And the last one is the seal. That means you covered all the ostium of the appendage. You do not have any gaps in between. Let's see that. This is a position. What I'm doing here, I'm putting the appendage as much as I can inside the ostium of the appendage, and I'm changing the angle. You can see that I'm playing with the angle in and out in order to make sure that I am at the ostium in all the views. This is the tug test. The interventionist now is pulling on the device in and out to make sure it is really caught inside the appendage, and you can see that in echo. The size, the compression, you have to get a view to see the knob, the middle knob of the device, and then you have to see the two shoulders. That means you are right in the middle of the device. And then you measure from here to here, and then you compare that with the previous dimension of the device. For example, if the device was 24 uncompressed, you have to see this dimension inside the body between 19 and 22. It has to be compressed between 8% to 20%. So for example, if it was 24 and then you measure inside the appendage and you find it 23, that means compression is not good. That means the device is still smaller than the appendage. You need a bigger one in order to get more compression. Okay, and then the seal, you do the same thing, change the angles to make sure you are covering all the ostium. There is no gaps in between. So if PASS criteria are met, you tell the interventionist, okay, you can release this device, and this is how it looks after the release. This is how it looks in 3D in day 0 inside the procedure. We repeat that after 45 days, and then these features will be muffled, will not be that clear like now because of the endothelialization, and there is no gaps. So we make sure that there is no gaps after 45 days. If there is no gaps, endothelialization happened, the device is in place, then the patient can safely stop the anticoagulation. Of course, complications can happen like any interventional procedure. Thrombosis is very common in these patients. You can see catheter-induced thrombosis. These patients have atrial fibrillation, large left atria. They are already thrombogenic. So there is a big chance of having this. So make sure that you optimize the ACT during your procedure. So as a conclusion, 2D and 3DT are crucial in this kind of procedure. It creates a common language between you and the interventionist, and it can replace CT if the patient for any reason can't have CT done, maybe renal failure or so. And thank you so much.